All right, well, I seem to have woven together a number of my sessions this evening, so I'm going to share a few things with you, but I want to start by just explaining where I live in the industrial design world, really. So I'm used to physical products. That's what I mean, we design user interfaces as well, but they tend to be the interfaces that are, software interfaces that are embedded into physical products. And most of our work is in the medical device area. So I want to talk about something a little different, maybe something we don't talk about all that much. And that is, what kinds of problems are worth working on? All usability professionals are design professionals. So we work on design problems. The question is, what do you want to come home at night and tell your wife and kids or your husband and kids that you worked on all day? And so I've created a little continuum here that I call the design venality continuum. And I'm going to start at the bottom. The bottom is for wimps, people that are not able to really get into the serious venality, design venality. So that's design that saves lives. And so I want to, this is all my way of explaining why I like working in the medical area, so we'll come back to that. Another kind of design problem is providing access to excluded users, and this is the term typically used in the U.S. as universal design. I happen to prefer the British term inclusive design on the grounds that nobody's really trying to design for everybody. But the concept is that people should not be excluded on the basis of their abilities. So that's this notion of inclusive design. Then there's improving work, making work better, figuring out how people's working lives can be improved. We're still in the land of the wimps. There's providing real pleasure to customers, and I'm so jealous I didn't get to work on the iPod. I think it's just an example of a beautiful product, especially if you hold the other thing, the other electronic product that I use constantly, that's constantly in my hands, and that's Microsoft Word. And when I compare Microsoft Word on the one hand to the iPod on the other, the contrast is just so completely dramatic. And I guarantee that the amount of money that they're spending on Microsoft Word is probably 100 times what they've spent on the iPod, I would bet. But what do they spend the money on? They spend it on new features. Hey, we've got a monopoly, guys. We have this huge margin. Okay, take some money and make new features. That's why we can't ever figure out how to use bullet points. Now, I've got a horizontal line, and I'm just kind of defining my universe. My universe, and all you can hold me to this, is we only work, my company has chosen to work below that line on the problems that I showed you so far, mostly on medical products, which I'm going to talk about at more length. But we simply won't do anything above the line. And I mean, everybody has their own threshold, but I guess one thing I'm advocating is just think about where your threshold is, and think about what kinds of problems we really should spend our time as usability professionals working on. Now, this is above the line for me, and this is making trivial stuff look cool. And it's above the line not because I wouldn't love to do it, actually. And by the way, this example is, I don't actually know if it is trivial or not, because I don't know what the hell it is, but it's Philippe Stark. That's the important thing. I consider the great genius of making trivia look cool. But so our company doesn't work on these kinds of problems, not because we wouldn't love to, but we're just not qualified to do that sort of thing. But now we're starting to get up into a little venality here, and here's what most design today is actually used for. Most design, and actually the dirty secret about the very profession of design, the whole profession evolved in the context of national brands. Now, what's the problem with the national brand? Suppose you're making Wonder Bread. Now, you want to sell that Wonder Bread to somebody that lives in some small town in Iowa who has a great local bakery that makes really good bread. So you got a real piece of garbage product that you need to figure out how to sell that person who has a better product, and you got to charge a premium because you got to ship it from California. That's where branding comes in. And honestly, much of the work of design is for just this. That is, to convince people that this stuff they call beer, this absolute crap, that they call it beer that's made from rice, is actually a really great thing to drink. So that's a problem that I won't work on. But then for the real pros, it's conning people into killing themselves. Now that takes real design. I mean, to make something so cool that people are actually willing to kill themselves to use. That is real design. At any rate, what I want to talk about is medical product design. And I'm even going to get narrower. Our goal at Design Science is to be as narrow as possible at all times. So I'm not only going to talk about applying usability to medical product development, but I'm only going to talk about one component of usability, and that's ethnographic research. I'm going to talk about that specifically because I think it's an area that perhaps the UPA, folks who are involved with the UPA, are perhaps not as used to or familiar with as things like usability testing and so on. Now, ethnographic research is done by ethnographers, that is, cultural anthropologists. This is the field that, as you probably know, it came from a time when people wanted to figure out what's the dynamic of these people in the Trobriand Islands or the Yamamano, if you took intro anthropology, these profoundly different cultures. And the cultural anthropology provides one with a set of tools for really parachuting into the middle of nowhere where you don't speak the language and you know nothing. And coming away with two things. And the two things are important, but they're not quite the same thing. Number one is a deep understanding of what that culture is. That is, what the kinship relationships are, who's the boss and who isn't, what makes them tick, what their values are, what their norms are. But in a sense, that's the easy part. The other thing that the cultural anthropologist can do is translate that knowledge back into our culture so that he or she can come to an anthropology conference and talk about the Trobriand Islanders or what have you. Of course, there are those stories you wonder about. They say that people went back to the Trobriand Islands after Margaret Mead did her famous research and started interviewing people, and they said, "Oh, Margaret Mead, oh yeah, she was that woman. We made up all that hilarious stuff, and she bought all of it." However, the idea of ethnographic research applied to product development is to take that same kind of thinking and those same skills and try to understand what the context is that a new product will go into. So that's what ethnographic research is all about. It's about taking these ethnographic tools, going into the field, and studying what people do. And that's what I'm going to talk about for the rest of my brief minutes with you. So I want to talk about one thing first of all and get this out of the way. And there are two sides to this. There's how do you make sure you're right? That's the science side. And then there's the art side, if you will, or to use Karl Popper, the philosopher of science's old notion, is that science consists of two things. It consists of conjectures and reputations. That is, you come up with some kind of wild conjecture. That's the creative part. And then you try to refute yourself and, in a sense, squeeze the error out of it. That's the refutation part. So I'm going to talk about the refutation part first. The key issue then is validity. That is, how do you know that the information you gather maps accurately onto the real world? Now, in the case of usability testing and so on, most of that really comes from social sciences like psychology and perhaps sociology. And the notion of what's valid comes from statistical procedures and so on. Anthropologists are used to thinking of and achieving validity in a different way. So I want to spend a little bit of time talking about this. I think this is important because I don't know about your world, but in my world, that is the world of industrial design, there is not an industrial designer in America who doesn't claim to be an expert on ethnographic research. What they mean, it's a kind of a hot thing right now. But what they usually mean is, well, I got out of the office and looked at some people doing some things. I want to say a few things about what real ethnographic research is. It requires scientific methods, so that it means having a formal protocol, as I'll talk about in just a second, having a specific methodology, having a way to gather the data, having a conceptual framework so that when you see something, you have a way of looking at it. When you see something, you don't just see a person and a machine, you see a social relationship, you see a status hierarchy, etc., etc. So it's a set of conceptual tools like that and scientific methods, although scientific methods that are quite different from those of sciences like psychology. So there's the next thing is to have a detailed protocol, and I think this is often where people try to understand when they're doing field research. This is where they often fail. That is, I know it's very common in the medical world. You say, well, have you all done any research? Oh yeah, we were just in the operating room yesterday. Well, what did you come back with? Well, they came back with some anecdotal information, and that's simply not good enough. That in order to have something better than anecdotal information, you need, among other things, a formal protocol, as you do with any other research. And I talked a little bit about error reduction. In the case of ethnographic research, the way that one eliminates error, addresses error, it's quite different. It isn't using the probability of 0.05. It's a rather different mindset, but it also has its own way of achieving validity, and it's this. When you're in the field studying something, you generate hypotheses. You know, your hypothesis might be, oh, the real boss. I'll put it in the context that I know. Let's say in an operating room. What's really driving the operating room? Who's really making the decisions? The behavior is a function of whose decisions? Is it the surgeon? Is it the hospital administrator? You know, et cetera, et cetera. So you might form a hypothesis. That is, they use equipment because X, Y, and Z. Or the kind of equipment that's really going to be appropriate here is X, Y, and Z. And then you test your hypothesis. You test it by doing something and simply seeing what they do. And here's an example of a cultural norm, at least in the operating room. Walk into an operating room during surgery without a mask on. It's as if you walked in buck naked. And that's something that the rest of us, you know, whether or not you wear a mask, it's not something that we're particularly tuned into. But just try it sometime. Walk into an operating room in scrubs, but just don't, and just leave your mask down. And of course, you know, I'll bet people have actually studied this, and I'd be really shocked if it matters, to tell you the real truth, at least until you're within the so-called surgical field. But boy, just being in the operating room without a mask on. So that would be a hypothesis you might form, that one of the behavioral norms here is that under no circumstances can you ever have your mask on. You can test that really simply by walking in without a mask. Or you can ask certain kinds of questions. You think through the logic of, if something was true, what would follow? What kinds of answers should I get to certain kinds of questions? So that the hypothesis testing for the cultural anthropologist is this cyclical process of forming hypothesis, testing the hypothesis, refining the hypothesis, testing it again, and so on and so forth. Again, it's not just going into the field and watching people. So there's hypothesis testing. So that's a little bit about the validity side, the science side. And I expect that's the side that you're probably the most comfortable with. Now, one of the things that usability professionals are always whining about is, oh, they don't get us involved early enough. They don't appreciate us, you know, et cetera, et cetera. Okay, so okay, we've heard it all. I'm not gonna make that point. I'm not gonna make that point. Although I agree with all of it, of course. I'm gonna make another point. That is, not only is it crucial for usability professionals to be involved in design, so I want to make the inverse point. It's absolutely crucial for designers to be involved in the usability research process. Why? Because usability professionals on their own, and just go to the Human Factors Society conference if you don't believe me, are incapable of presenting information in a way that's clear and usable to business professionals. They simply are incapable of that. It's a rare person that doesn't put up lots of graphs and charts and mountains of text. Nobody's, I hate to tell you the bad news, people are not going to read these reports that you produce. So I want to talk about that. Now when we're out in the field, to use ethnographic research as an example, although the same principles apply to other kinds of research, but to use that as an example, you get this messy, sloppy, seemingly incoherent data. And I want to give you some thoughts about how now you put it into a coherent and usable form. So, now, I have the advantage of being absolutely bone lazy. So I never get any new clients. I just work with the same clients year after year after year. So the things I'm going to share with you I've refined, or our company has refined from working very closely especially with Ethicon endosurgery we do a lot of work with. So what we've done is we came to them. We used to have the same problem that I think probably a lot of us have, is you write the report, you give it to the design team, a few of them read it. Some of them at least know the executive summary, but hardly anybody reads through the whole thing and studies, except that one engineer who comes back and asks you some esoteric question from the Appendix C that you didn't even think anybody was going to look at. But here's the thing, at least in product design, in the product design world that I know. The first generation of concepts, that is the purpose of this kind of research, is to figure out what the hell you should be designing in the first place for it. So typically, we do this ethnographic research, we present our results, we with all these ideas about what's not working now in the field, what they need to do, and so on. First generation of concepts would reflect a lot of the ideas that we provided. But then there's the second, the third, the fourth, and in the medical world, typically 4 or 5 generations of refinements and so on. By the time you get to the second, let alone the third or fourth generation, nobody remembers the original research. So there's the research or the data, the information doesn't have durability. And that's one thing, that's one issue. Issue number 2 is how do people in business, at least in the product development world, on the whole R&D side of businesses, how do they make decisions? How are decisions made? I mean real decisions. You got 2 pathways. You got a product, you got a why. You're staring at the fork in the road and you want to know which way do I go. How are those decisions made? How are the hundreds of those little fork in the road decisions made in the development of a product? They're made in interdisciplinary groups. Everybody that we work with, anyway, they're made in interdisciplinary groups in conference rooms when people they discuss things for a while. Everybody has their say, and then a decision is made in the room, in the conference room, right then and there by the group. At least that's my experience and the kind of work that we do. Now, how often does somebody then say, okay, should we do this or that? Oh, let's go look at the report. Yeah, that's on page 32 of the report. There's some data that's relevant to this decision. No, it just doesn't happen. So the next thought is that if you put I know this sounds like a trivial idea, but if you take the key information, you put it in the form of a poster that stays up on the wall, it addresses that issue of information durability. So this is an example of a poster that I have up here. I've intentionally kind of dumbed it down and made it too small to see all the details and stuff because it's so this is proprietary stuff. But the general idea is what this happens to be is and my examples just happen to come from surgical procedures because that's what we've been studying a lot lately. And this is a surgical procedure. On the horizontal axis is time. The vertical blocks are the basic components of the procedure. The horizontal, the various rows represent different instruments. The different colors represent who is using the instrument. So if you know Edward Tufte's kind of work, this is Tufte-esque kind of thing. Taking a bunch of complex, much of it quantitative data, and putting it into a form that you can see at a map. See at a glance. And that's, by the way, why we call them procedure maps. Because like a map, Well, what does a map allow you to do? It allows you to see the big picture at a glance without having to think about it, and then to look closer when you need specific information, and that's what this does. So it works as a map in that sense. Now, I'm here to tell you, that I've never seen anything quite like this in my career. The following things. The following things happened when we started doing this. And by the way, this basic concept, we gather the data. I'm not trying to say we're great geniuses about how to do this, because this wasn't really our idea. This was our client's idea. They were the ones, our client's design team were the ones that worked with us and came up with most of the basic concept on how to do this sort of thing. Now, when we used to give them reports, I talked about some of the issues. Now, when we summarize the information like this, and I'm going to show you some other things too, but I don't mean to say this is the total story. You still need appendices with all the data and the Excel spreadsheets and all that, but no one's ever going to look at it, or few people will. But what they will look at is something like this. Now, the following things, to use this as an example, I'm literally describing the situation. This isn't hypothetical. The first thing that happened is the upper management types never used to give a rat's ass what was happening down in the usability lab and what the designers were doing. They really didn't, because they don't care about products. What they care about is the big picture and quantitative, the big picture, particularly from a quantitative point of view. All of a sudden, you have something that the CEO can walk up to, and with about 2 or 3 minutes say, "Oh, I get it. So that's a cholecystectomy. I always wondered what the hell that was." And it allows you, that's a gallbladder surgery, sorry. It allows you to get a quick overview. So, whereas, by the way, as you probably know, just like usability professionals are always whining that designers don't involve them enough and early enough and don't respect them, blah, blah, blah. Designers always say the same thing about the engineers. The engineers probably say it about the MBA types that actually run the companies and so on. But at any rate, all of a sudden you got something that CEOs and that upper management can really get kind of excited about. All of a sudden, the management types are coming over to the design department and saying, "Wow, this is really cool stuff here. What are you guys doing?" Yeah. Okay, then the next thing that happened is one of the surgeons walked in by one day, and the surgeon says, "What's that?" "Oh, I would call that a procedure map. This one happens to be a colectomy, to take a piece of your colon out." "Oh," and then he'll say, "Oh, interesting. Oh, yeah. Oh, well, no, I don't actually quite do it that way. I do it this way." So all of a sudden, the designers and the engineers are able to have a conversation they could never have before, because there was no vehicle to have a discussion about how the procedure works. And one other thing, you've got this interdisciplinary team, and the problem is, there are a couple of problems with these teams. One is everybody sees things from a different perspective, even though they often use the same words. So when you sit down to start with the question of what is the problem here we're going to spend several $100 million to solve, no, the people are not on the same page. The team are not on the same page. They think they are, but they don't recognize that they're using the same words in different ways, and they have a very different understanding of what the underlying problems are they're trying to solve. So this kind of stuff gets people on the same page. The other thing is it takes away the veto power of the one-horse's ass on every team. There's always, every product development team, at least in my world, has one person that's actually been in the field for an hour or two. And he's the one, or she, it's usually a he, but he or she is the one who, whenever anybody suggests something, they say, "Oh, can't do it, the nurse just won't accept it." And nobody's in a position to argue with them, because, in the land of the blind, the one-eyed man is king, right? They've been in the field for an hour or two. Now, when that person does that, somebody walks up to the wall and they say, "Well, that's what you say, but look, this is a summary of 15 procedures that we've done all over the world, and we look at that, it doesn't look like, it looks like that doesn't really take as long as you're claiming," or what have you, and so on. All right, so that's a procedure map. How am I doing time-wise? Bad, good? Why don't you just give me a time? Okay. Here's another one. Now, the procedure map I showed you before, the difficulty with it is it's abstract. It's really the distillation of certain kinds of quantitative information. There's also the question of just intuitively, what are the procedures? How are things done? And so for those, we use this thing called a scenario. And all it is a storyboard showing the steps of different procedures. So that this particular example here has 4 alternatives. These are 4, the same procedure performed in 4 different ways. So when we're out in the field studying these things, we find variations. And in a sense, this is, to go back to the procedure map, this is taking one little component of the procedure map and blowing it out and showing you what's hiding in this little square, so to speak. That's what these are, these scenarios. And again, it gives people an intuitive understanding of how procedures are done. What are the procedures that we're talking about here? And in the most typical case, the team thinks that everybody does it this way. They don't realize there are 3 other ways of doing it. And how this kind of thing is often used is in concept development. That is, when people are generating different alternative ideas, they'll kind of hold those ideas up and say, okay, now, which of the procedures is this one going to be incorporated into? Or will it be a 5th? It's different from those. So it kind of gives you a way to think through a little bit of what the implications of your new instrument are, in this case, for removing the specimen. How are we going to remove the specimen? How is that going to compare to these? And then personas. This one I don't have to dwell on. I presume that everybody at least knows what they are, whether or not you use them. Just to comment, the key thing with personas, I think, is just to make sure that they're accurate. You know, you can really get off into space if they start moving away from reality. So that's just the important part of that. And we find just text summaries in the first person. That seems to work. And also that when we do this kind of ethnographic research, people sort of naturally fall into these persona categories. And here's another one. This is, again, all these are from medical procedures. So just a plan view of the operating room. But what it's got is it's got a couple of things. What are the patterns of communication? That's what the green is. Who talks to who? And then the dotted lines are patterns of movement. Where do people move? And in terms of developing medical devices, this, of course, is crucial. You want to understand, this space up here above the operating table, it counts. Where can you stick something there, and where can you not stick something there? What's the pathway? How can you make the pathway of movement easier? Where are people looking? And all that sort of thing. All of these, by the way, are the distillation of several different procedures into these kinds of averages, but they're data driven. So much of the data are instead of the size of the actual table, this will be an average of that table, unless there's too much variability, and then we'll do a second one to represent if it falls into a bimodal distribution or what have you. Now, the other thing is video, and that is when one is in the field, you end up with a lot of data. You end up studying a lot of procedures, and video is the pro forma tool these days for any kind of ethnographic research. So you end up with a lot of video. So we started off with video for working on these kinds of problems. We started off with pretty standard video. The first thing that we recognized is the resolution wasn't good enough to see what we needed to see. Because you really, in the case of a medical procedure, you really have to understand what's going on at the business end of the instrument in great detail. So we quickly recognized that we were going to need higher resolution than we were used to. So here's just a... this is the kind of stuff we stare at all day, and this is medical product development. I think that's a gallbladder there. Pretty healthy one, actually, for Joe. But Anyway, so we end up with a lot of video like that, with this high-resolution video. Now, so we start with low resolution, then we had high resolution. Then we quickly recognized that we didn't really know enough because we had to know what's going on in the business end, but that's too close in. We also want to know who was handing what to whom. Do they have ergonomic problems with their arms and so on and so forth. Anyway, so we quickly ended up, or not too slowly, we ended up with multi-channel systems. So now we come in with multi-cameras. So in this particular example, here's the business end of a laparoscopic instrument. Here's kind of an overview, and here's an overhead shot, kind of a dynamic plan view. It seems to work for the kinds of information that we're pulling out. And of course, we study these. We spend hours studying these in order to produce those procedure maps that I showed you before. So this required us to come up with this proprietary, well, to develop our own video system. It really needs to be digitized to be usable. And so, what's that?
Is it synchronized?
Yeah, those are, yeah, so we have 3 channels that are synchronized, and also it helps, of course, to gather the data digitally to begin with, and you don't have, tape stretching and all kinds of weird stuff like that. It gets them out of sync. However, that's not good enough either, because there's another problem. When you end up with hours and hours of video, as we do, we were just looking at the video for one project, and it was, it was about 100 hours of high resolution 4-channel, well, 3-channel in this case, multi-channel video. So now, if we go back a bit, if any of you ever have worked in the video, and if you have, let's go back to tape, videotape. I don't know, a lot. We used to have a box full of videotape. How often did you ever go back through the box to find the right thing that you needed at any given time that just wasn't accessible? So turning the video then into a searchable database by categories, and that's the next logical step. And so that's ended up being a real crucial tool for us. Some of the other things that allows us to do is speed it up, slow it down. In the case of a procedure, some things you can't see until you look at the whole procedure. Take an 8-hour procedure, something like a, heart bypass. Not 8 hours, but it can take 3 or 4 hours easily. But you can't you lose yourself in the trees and you forget the forest. And so doing fast forward, looking at the big picture in about 15 or 20 minutes can sometimes reveal things you can't see otherwise. Just like the reverse is true. Sometimes you want to look at slow motion. Look at those little details, like what exactly are the wrist angles and so on. So that's another thing. And then just something real simple. This is the simplest thing in the world. And that is just to summarize all the basic characteristics of the ideal product and stick it on the wall. We call it a wish list. Stick it on the wall just so people don't forget what the end goal is. And this is usually above even what's typical, what's doable today. But this is the perfect product, or our best estimate of what the perfect product is. That is the end target that one should shoot for. And by the way, a simple thing that at least some of our clients that we're working with this kind of thing is that simple rule. You can't have a meeting. The team cannot have a meeting except in the room where all this stuff is up on the wall. Obviously not the video, but the other stuff are literally posters that stay on the team room whenever they're working on a given problem. So that's all I have to say about that. Just one other thing is that what we're working on right now is taking the notion of a video database and reorganizing it into a video array, so that you can search now hundreds and hundreds of hours of video, all in from one workstation, basically, as if it were just one body of video. Putting it all on hard drives. So we're always looking. If anybody is in the hard drive business, the biggest hard drive, whatever it is, that's what we're always looking for. So because it changes the nature of our work. Okay, so that's all I have to say, and I'm willing to answer questions or listen to diatribes. Yes?
Are you searching your video on keywords or on some kind of a visual metaphor?
Keywords. Yeah, that's maybe the next step. It's one of those things we talk about. we haven't figured out anything that, at least for the kind of stuff we're working on, that from a visual search a device that works. We haven't figured out how to do that. So what we'll do is we'll say, well, we're doing it right now, so I can actually discuss it accurately. We're saying, we come to the team and we say, okay, now what, when you're, and by the way, just a couple of examples of how they use the video specifically as a tool. The team will just wallow in it. They'll just say, okay, we're working on some new instruments for gastrectomy. That is when they remove your stomach, a procedure you never want to have. You pray to God right now. Start praying right now. It'll never happen to you. Okay, but they're designing a new instrument for gastrectomies. The team will just wallow in the video. They'll just watch video of these multi-channel views of gastrectomies for a day to just kind of get a sense of what it is they're designing for. And by the way, the other thing that's impressive about, I think, particularly about Ethicon, that much of this work was done here, is that they finally, you know, the old saw about, you know, they used to think they were in the medical device business. Now they understand they're in the medical procedure business. So we used to work on a specific instrument. You know, we used to say, okay, well, we got a new surgical stapler. We need your help. No, now they say, we want to improve gastrectomy surgery. We need your help. And we'll figure out, and we want you to help us figure out what instruments we need. They don't start with a proposition. They need a certain kind of instrument. So anyway, so they wallow in the video. So we'll come in and we'll say, all right, what kinds of searches might you do? What are the dimensions that are going to be interesting to you? Well, let's say, well, Europe's different than the U.S. Okay. What country? All right, fair enough. And then we're interested in problem cases. Okay, so we'll flag the problem cases versus non-problem, and so on and so forth. So we'll sit down with them, come up with a set of keywords in effect, and then mark all the video on the basis of what those keywords are. So just like any other data, we're just like an ordinary database. But it calls up conceptually, positions in a body of thousands of hours of video. That's the idea. Yeah?
How far down the chain do you go? Like, you get the play prototype and all the way down to the hardware, and then it comes back? I mean, where does that...
Well, in our case, I only talked about that. Our process is this, and again, since we've been working for the same old clients, we have integrated ourselves pretty fully. And so it starts with ethnographic research. And then the next thing, as they start developing ideas and products, we participate to some extent in that process, but that's when the little, the technical human factors questions come in. That is, what does the geometry of the instrument need to be? How much force? That really hardcore human factor stuff. So we'll work with them on that sort of thing. But then as soon as a prototype is ready, and I'm using, I'm using a surgical instrument as an example, but the same is true of a software-driven device. But for us, it's embedded software. We wouldn't typically work on a website. So then some kind of form of prototype will become available. On the software side, we'll create the prototype. And then we do usability testing. And then that's a cyclical process, and I'm sure everybody in the room, or most of you, are highly familiar with. It's the same thing. So our last, one of the dirty secrets, is this on tape? One of the dirty secrets is that FDA in the usability area, I don't say this too loud, it's just your friend. Everybody complains about the FDA. But what the FDA does is they slow the process down. And they enforce usability. I mean, if you don't do usability in the medical area, you've broken the law. It's against the law not to do usability testing. Literally against the law not to do usability testing. Don't you love it? And so what in the medical, the term of art is that the final test is I think the language of the language of FDA reads something like, it's called validation. And it reads something like, you have to, that its validation is defined as the testing of actual production parts or their equivalent. And there's always some wiggle room for what is their equivalent. But that's the last kind of test, the validation. The earlier kind is usually called verification. That's just the way that the terms that the FDA uses. But The point is that you have to do that final validation, that summative usability testing, and we're usually involved in that, as we've been all the way from the ethnographic research all the way through into those specific products. Got time for another question or two? Okay, he's giving me that, oh, you're using your time up. I talk to you, Rob, all the time. So yeah.
The question that I had is, with the video shooting you're shooting and all the data that you end up getting, and with all your diagrams, that's an enormous amount of data, and that's a lot to deal with. How do you make sure that your sample size is valid as well?
Boy, that's a great question, and it's the same answer for any kind of research, and that is I know this isn't satisfying, but it's driven by variability. Sample size is always driven by variability, and in this kind of case, there's really no test, there's no statistical test that's really applied that is relevant. So we've kind of, from years of doing this kind of thing, we kind of have a sense of what sample size we need in order to see kind of the universe. But what's interesting is our work, and I didn't talk about this, but it's an important point. Our work is usually backed up with some kind of quantitative research of one sort, a different kind of quantitative research. So we'll say there are four kinds of, there are basically four kinds of surgeons. They do it in three kinds of ways. But we can't actually put frequency, overall population frequency numbers to that. But we can tell them what questions you should ask to figure out what those population frequency numbers are. And then that's somebody else's research project we don't know. Okay?